Acute respiratory distress syndrome is a rapid onset condition characterized by severe dyspnea, hypoxemia, and diffuse pulmonary infiltrates. It leads to acute respiratory failure and requires urgent critical care management. It results from either direct lung injury such as pneumonia or aspiration, or indirect injury such as sepsis or trauma. Incidence before COVID was approximately 60 per 100,000 per year and accounts for about 10% of ICU admissions. Risk factors include older age, chronic alcohol use, high APACHE2 score above 16, and multiple predisposing conditions. The exudative phase occurs within day 0 to 7 and involves alveolar epithelial and endothelial injury. Protein-rich edema, hyaline membrane formation, and neutrophil influx dominate this phase. This leads to alveolar collapse, reduced compliance, and severe hypoxemia. Radiology shows bilateral pulmonary infiltrates, and laboratory findings reflect the underlying cause. The proliferative phase occurs from day 7 to 21 and represents early lung repair. Type 2 pneumocytes proliferate and surfactant synthesis resumes. Some patients continue to have dyspnea and hypoxemia with early fibrosis developing. The fibrotic phase occurs after 3 weeks in some patients and involves extensive fibrosis. This leads to disrupted lung architecture, pulmonary hypertension, and increased dead space. Some patients require long-term oxygen therapy or mechanical ventilation. Diagnosis follows the Berlin definition, requiring onset within 1 week of insult. Chest imaging must show bilateral opacities not explained by effusion, collapse, or nodules. Oxygenation is assessed using the ratio of arterial oxygen partial pressure to fraction of inspired oxygen. Mild ARDS is defined as ratio between 200 and 300 millimeters of mercury. Moderate ARDS is defined as ratio between 100 and 200 millimeters of mercury. Severe ARDS is defined as ratio less than or equal to 100 millimeters of mercury. Measurements must be taken on at least 5 centimeters of water-positive end expiratory pressure. Pathophysiology involves alveolar edema causing shunting and severe hypoxemia. Hyaline membranes lead to surfactant dysfunction and alveolar collapse. Neutrophil infiltration causes inflammation and oxidative damage. Microvascular injury leads to pulmonary hypertension and increased dead space. Differential diagnoses include cardiogenic pulmonary edema, bilateral pneumonia, and alveolar hemorrhage. Management begins with treating the underlying cause such as sepsis or pneumonia. Standard ICU bundles include venous thromboembolism prophylaxis and gastrointestinal bleeding prevention. Mechanical ventilation is indicated for progressive hypoxemia and fatigue. Low tidal volume strategy uses 6 milliliters per kilogram predicted body weight. Plateau pressure should be kept less than or equal to 30 centimeters of water. Positive end expiratory pressure prevents alveolar collapse and improves oxygenation. Prone positioning improves oxygenation and reduces mortality in severe ARDS. Extracorporeal membrane oxygenation is used as rescue therapy in severe cases. Fluid management aims to reduce pulmonary edema while maintaining perfusion. Neuromuscular blockade may be used early in severe cases with ventilator dysynchrony. Glucocorticoids do not show consistent mortality benefit and are not routinely recommended. Inhaled vasodilators may transiently improve oxygenation but do not improve survival. Hospital mortality ranges from 35% in mild to 46% in severe ARDS. Mortality is often due to non-pulmonary causes such as sepsis and multi-organ failure. Most survivors regain near normal lung function within 6 months. However, reduced exercise capacity and psychological sequelae may persist for up to 5 years. Early recognition, lung protective ventilation, and treating the underlying cause remain the cornerstone of ARDS management.